In the field of clinical pharmacology, few medications present a more striking operational divide across age groups and bodily systems. The molecule driving these disparate effects is imipramine, a classic first-generation tricyclic antidepressant, or TCA. Its primary and most heavily utilized clinical indication is the treatment of adult depressive symptoms, yet it maintains a highly specific secondary adjunctive use, the temporary treatment of nocturnal enuresis, or bedwetting, in selected children 6 years and older. Developed in the 1950s as the first tricyclic antidepressant, imipramine established the pharmacological blueprint for treating mood disorders, a standard that remains active 70 years later. The clinical paradox emerges immediately. How does a single molecule alleviate major depressive disorder in adults while successfully preventing involuntary urination in children? The answer lies in its pharmacology. Imipramarine's therapeutic power, alongside its massive side effect burden, originates directly from a lack of receptor specificity. Mastering this drug requires the clinician to account for not only what the molecule targets intentionally, but what it strikes by accident. To observe the intended mechanism, we have to look down at the microscopic level of the synaptic cleft in a depressed patient. This simplified model shows the presynaptic neuron releasing two key neurotransmitters, norepinephrine and serotonin. Under normal physiological conditions, these transmitters activate receptors and are quickly reabsorbed by the sending neuron through reuptake transporters. Imipramine directly interrupts the cycle. The molecule binds to and inhibits these specific reuptake transporters. As a result, the transmitters cannot be reabsorbed, causing the synaptic inhalability of both norepinephrine and serotonin to significantly increase. This sustained reuptake inhibition serves as the primary proposed mechanism for imipramine's efficacy in treating depression. Conversely, the exact mechanism for treating pediatric enuresis is unestablished and likely involves entirely different peripheral pathways. While inhibiting reuptake addresses the psychiatric target, this crude molecular blockade triggers a chain reaction of unintended consequences throughout the body. Beyond the brain, imipramine hits multiple off-target receptor types across systemic circulation. This broad receptor affinity reflects early drug discovery, an era when molecules lacked the targeted precision of modern selective inhibitors. This matrix maps the off-target receptor hits, beginning with anticholinergic blockade. When imipramine blocks cholinergic receptors in the gastrointestinal tract and mucosa, the patient experiences severe dry mouth and constipation. When that same blockade affects ocular and renal systems, it induces blurred vision and urinary retention. The second major category is alpha-adrenergic blocking effects. Inhibiting these receptors compromises vascular tone, leading directly to dizziness and postural hypotension, a rapid drop in blood pressure upon standing. The third category comprises antihistaminic effects. Blocking histamine pathways drives the neurological symptoms, presenting as profound drowsiness, weakness, and fatigue. Because of this, prescribing guidelines demand extreme caution alongside alcohol, which severely compounds the drowsiness and critically impairs motor operation. For the clinician, there is no such thing as a random side effect. Every adverse reaction is a predictable, direct consequence of its multi-receptor pharmacology. Understanding where the drug acts must be paired with understanding how long it takes to act. This dual-axis graph tracks the drug's pharmacokinetics. The first line represents imipramine's half-life, the time it takes for blood concentration to reduce by 50%, which occurs in a tight window of 8 to 20 hours. During this window, it is extensively metabolized in the liver, producing desimipramine, a highly active secondary metabolite that continues to impact the patient. However, a dangerous clinical disconnect exists. Despite the rapid metabolic clearance, the actual therapeutic benefit for depression is severely delayed, taking a full 1 to 3 weeks to materialize. This establishes a strict clinical rule. A drug's half-life does not equal the duration of its therapeutic effect. The greatest risk during this lag phase is impatience. An anxious patient might prematurely increase the dose, assuming the initial prescription has failed. Managing a patient on imipramine requires separating the reality of rapid metabolic clearance from the much slower process of neurochemical adaptation. Because imipramine has an exceptionally narrow safety margin, prescribing demands highly individualized, heavily restricted dosing strategies. This graphic compares the two distinct protocols. The adult depression pathway begins at 75 to 100 milligrams per day for outpatients or hospitalized individuals. While this is gradually titrated upward based on tolerability, guidelines generally do not recommend exceeding 200 milligrams per day for outpatients. Contrast this sharply with the pediatric enuresis protocol, which dictates an initial dose of just 25 milligrams per day for children 6 years and older. The depression and bedwetting dosing protocols must never be interchanged. Getting the dose wrong invites catastrophic consequences. TCA overdose is a high-acuity medical emergency. The cardiovascular toxicity is frequently lethal, manifesting as severe arrhythmias, drastic ECG changes, and profound hypotension. The neurological toxicity is equally severe, triggering seizures and profound confusion, a risk highly elevated in elderly patients. Consequently, extreme caution is required for patients with a recent myocardial infarction, glaucoma, or urinary retention. A flawless medication history is an absolute necessity. Combining imipramine with MAO inhibitors is highly dangerous and requires strict, medically supervised washout periods. This steep toxicity curve is why imipramine has been largely superseded by safer SSRIs as a first-line treatment, relegating it to specialized use cases. That brings us to the most counterintuitive aspect of current U.S. labeling regarding pediatric use. Imipramine is strictly not approved for pediatric depression. Clinical data dictates this restriction. Antidepressants like imipramine carry a highly monitored risk of inducing suicidal thoughts and behavior in children, adolescents, and young adults, which resolves the core paradox we established earlier. If it carries this level of risk for young patients, why is it prescribed for bedwetting? It is utilized for enuresis strictly as a temporary adjunctive measure in highly selected children, and only after all underlying organic causes have been thoroughly evaluated and ruled out by a physician. This summary matrix outlines the drug's complete profile. Imipramine is a tricyclic antidepressant that inhibits norepinephrine and serotonin reuptake, carries heavy anticholinergic and adrenergic off-target effects, features a delayed therapeutic onset, and requires meticulous toxicity management. Proper drug selection, accurate dosing, and the necessary tapering schedules to avoid abrupt discontinuation must always be managed by a qualified prescriber. Ultimately, imipramine functions as a powerful, blunt instrument, one that requires a clinician to balance its potent therapeutic effect against a vast systemic footprint of off-target activity.